Hello, I'm Alicia, the Executive Director of the Myasthenia Gravis Foundation of Michigan. Thank you for joining us for our 2020 Annual Patient Educational Conference. Though the current pandemic has kept us from being able to gather at this time in person as we have in the past, we have been able to connect with many amazing presenters to record a lot of important information to share with you, our MG family. Dr. Margaret Frey is a board-certified neurologist with the Memorial Healthcare Institute for Neuroscience in Owosso, Michigan. Dr. Frey provides a wide range of neurology services with a specialty in the treatment of complex epilepsy and muscular dystrophy. She has completed a fellowship in neurophysiology and serves as the medical director of the MDA ALS Center in Owosso, where she sees MG patients as part of her clinic. Dr. Frey is an assistant professor in the Department of Neurology at Michigan State University and serves as co-director of the MDA ALS Care Center at MSU. She is also a member of our medical advisory board. Please welcome Dr. Frey with her talk on understanding, living, and thriving with MG.
Hi, I'm Dr. Margaret Frey. I'm a neuromuscular specialist from Michigan, Memorial Healthcare in Owosso, Michigan, and I take care of a lot of people with myasthenia gravis, and I'm here to talk with you today about what is myasthenia, what is the mechanism, how do we move, why do you get weak, and what can we do about it? So we'll talk about myasthenia gravis so that we can understand the problem. We'll discuss management concerns that commonly arise. We'll talk about medications in myasthenia, both medications that we use to treat the disease, what the medication purpose is, and then we'll also touch on medications that you have to be careful with when you have myasthenia gravis because they can actually exacerbate the condition. And we'll talk about exercise and therapy. People often in the neuromuscular world will have a feeling that they might hurt themselves when they're exercising, and that's a valid concern. So we'll talk about what are some of the constraints that you want to just be careful with when you're exercising with myasthenia gravis, and in what way can therapy be helpful. So what is myasthenia gravis? Myasthenia is an autoimmune disorder that causes fluctuating weakness of voluntary muscles. The fluctuating weakness is produced when antibodies block the communication from your nerve to your muscle. This causes the muscles of patients who have myasthenia gravis to start out okay, but then rapidly fatigue because they're not getting adequate communication from the nerve. There's a wide variability of disease manifestations and severity. Some patients who have myasthenia will have really pretty mild symptoms. They may have a little droopy eyelid or a little bit of double vision. Other patients may struggle to stand, walk, or even breathe and swallow. And so they're all manifestations of the same basic disease, but it's really variable. Myasthenia tends to affect females more frequently than males, and it tends to affect females at an earlier age, often in their 20s or 30s, whereas men tend to be affected more in their 50s and 60s, a little bit later in life. So the question, I think, the place to start when you're discussing a disease state is, well, how do we normally move? And we move when an impulse comes to our brain. Our brain says, hey, legs, I need to walk. So the coordination comes from the brain through an impulse down through your spinal cord, through your nerves and to your muscles to make the muscle contract and coordinate and organize walking. The nerve communicates with the muscle through a structure called a neuromuscular junction, and it does that by releasing a chemical called acetylcholine. Acetylcholine binds to receptors on your muscle that then tells the muscle, all right, it's time to contract. And so the muscle contracts and you're able to initiate movement. Myasthenia gravis causes a problem at this level. So what you have happen is that neuromuscular junction, which you see here as little squares, the neuromuscular junction, the acetylcholine receptor there gets blocked by antibodies, which are often depicted as a little Y-type structure. So the antibody binds to that acetylcholine receptor, and now the acetylcholine can't bind. And so your nerve can no longer communicate with the muscle because the spot where it needs to go to communicate has been blocked. The acetylcholine receptor, sometimes when the antibody binds to it, also gets destroyed. It gets taken into the muscle, and then it simply, not only is it blocked, but it's no longer present. And you can have damage to the neuromuscular junction from that process. This is another schematic just showing what a neuromuscular junction looks like. So we see a normal neuromuscular junction with its little vesicles, our normal nerve with its little vesicles full of acetylcholine being released into the space of the neuromuscular junction. The acetylcholine diffuses across, it reaches its receptors, and it sends a signal to the muscle telling the muscle to contract. On the other side here, we see the antibodies, again, blocking those receptors. They're impairing the ability of the acetylcholine to bind, and they're also at times causing the receptors to be destroyed. So you lose some of the muscle contraction. Now, you may not get complete destruction of the receptors. Some of them are still getting some signal, and so you get a little contraction, but it's not what you need. And so what you perceive then is weakness. There's also receptor degradation that comes from this process. Our immune systems are fairly complicated. We have antibodies, and most of us are familiar with the idea of an antibody, the structure in our blood that fights infection, and when it's not doing its job well, it can even attack the person that it's supposed to be protecting. But sometimes these antibodies then will initiate sort of a second response from something called complement. The complement cross-links these antibodies, and it ends up forming something called a membrane attack complex. And when that happens, that immune response, that membrane attack complex, does more than just prevent the muscle from communicating in that moment. It destroys the neuromuscular junction. It causes damage to the neuromuscular junction in a way that leaves not just in the moment, but long-lasting weakness. And that's a process that we really need to get our arms around and make sure that we're preventing as much as possible. There's lots of different antibodies in myasthenia gravis. The one that we think about most commonly, because it's the most common antibody, is the acetylcholine receptor antibody. But the neuromuscular junction is complicated, as the immune system is in medicine and science in general. There's another antibody called anti-MuSK, and it works in a slightly different way. It prevents the what's referred to as clustering of the acetylcholine receptors. So the acetylcholine receptors are spread way too far apart, and it just reduces the efficiency of the neuromuscular junction. And again, that produces weakness. There are other antibodies that attack similar proteins kind of in that same complex. And I just wanted to touch on the fact that these exist because I'm speaking to folks with myasthenia gravis, and undoubtedly there are patients in our audience right now who are facing this variant of this disease. So what happens when our muscles get weak and when we start to feel the effects of the myasthenia? It affects everything. The eyes have a very high rate of need for stimulation from the nervous system, metabolic demand. Our eyes are super active. Our eyelids have to stay contracted. Our eyes are moving all the time. And because of the amount of activity and sustained contraction of those muscles, we often will see problems there. Manifests as droopy eyelid because the eyelids just can't do it anymore, or double vision. We see limb weakness in the arms and legs that can cause difficulty with lifting your arms, bathing, showering, washing your hair, brushing your teeth, eating, or difficulty with walking. We often will see trouble with swallowing and difficulty with chewing, and it's not uncommon for people to fatigue very quickly in the jaw because they've used up all of their acetylcholine and the receptors are just not getting enough stimulus, and the jaw just gets weak. It doesn't have the amount of stimulus there that it needs to keep on going when you're trying to chew through a hamburger or a tough steak or something. And then again, you feel fatigue. And occasionally we'll have patients who get so much fatigue there that they have to actually lift their jaw up with their hand to assist with chewing. Breathing can become difficult, and when this happens, it's an emergency. We see facial weakness, slurred speech, nasal speech because of weakness in kind of inside the nose and mouth structures. We see neck weakness or difficulty for people sometimes can't even hold their head up. And then the myasthenic crisis is when breathing is affected, swallowing is affected, and without hospital support, people can die. Those are the common symptoms of myasthenia. That's what we think of initially, but then there are less common symptoms of myasthenia gravis. One interesting effect of myasthenia is the tendency for the eye weakness, the lids and the double vision, to worsen with bright light. And so a lot of times patients who have myasthenia will wear sunglasses and things to help reduce that input and worsening from that. People can have difficulty breathing when they're laying down, and that's because of the respiratory muscles feeling weak. And it takes a lot more strength to breathe, to take a breath when you're laying on your back. People will develop pain due to muscle aching or muscle cramping. Or remember how I told you sometimes people will have to lift their chin with their hand. Keeping your elbow bent like that can damage the nerve at your elbow, and so that can create its own problem there. And then when people have weakness, the mechanics of what they're doing changes. Your core is not strong. Your hips move in ways that they're not supposed to. And all of that creates extra stress on your back and your joints. And that can cause a problem as well. So we see chronic issues with back pain and hip pain, knee pain, and things like that that have to be addressed in addition to the direct effects of the myasthenia gravis. So what do we do about it? So you are developing some of these symptoms. How do we proceed? You know that you've got the problem. You have to bring it to your doctor to help you figure out what is the problem and where is the solution. So your doctor has to establish a diagnosis. They'll start to do that like any good doctor does by taking a very careful history and listening to you. And the history of painless weakness that fluctuates. People who wake up okay in the morning and then through the day they just get so, not just tired, but physically weak. So the history clues us in on where to look, and we'll follow that with some pretty simple blood tests to look to see, do you have any of those antibodies that we talked about before? There are tests that can help us, specifically electrodiagnostic testing or a test called an EMG, where we can look and see from an electrical standpoint, when we stimulate the nerve, does it communicate with its muscle correctly? We can do other tests to rule out different problems. People get weak for lots of reasons, and sometimes it's not exactly clear. So we'll have to do other testing based on your physical examination and your history to really sort out what's going on. Once we've pretty clearly established the diagnosis of myasthenia gravis, however, then we need to follow with some housekeeping. One of the first things we need to do is a CAT scan of the chest to rule out a benign growth called a thymoma. Which leads us to, what is the thymus? This is a gland that most of us probably never wanted to know we had or existed. But it's an important structure. It's part of our lymph system, and it's a gland that sits here in the chest. The thymus plays a role in the development of our immune response. It plays a role in the development of what's referred to as T lymphocytes. T lymphocytes are cells that are important for identifying proteins that are foreign to you and destroying them. It's also important for the thymus to identify antigens or proteins that are part of you and not destroy those or not attack those. And part of the normal immune system is to weed out any cells that are autoreactive or react against a person, but it doesn't always work well. About 10% of patients who have myasthenia gravis will have that benign growth called a thymoma. It's typically benign, but it can be cancerous, and when it's present, we take it out. The thymus of a myasthenia gravis patient does not appropriately eliminate the cells that produce antibodies that react against your own tissue, and that's part of the underlying problem. What are some other tests? Well, we want to do a good clinical examination, and here's just a couple of clinical signs that we'll sometimes see in the office that can help us sort out, is this likely to be myasthenia or is it not? One of them is something called an ice pack test, and how this works is when you apply the ice to an eye that's weak or droopy, the cold of the ice, it kind of helps to facilitate the communication in those muscles, and the weakness will go away for a moment. So we see here in the second set of images, a gentleman who's demonstrating for us something called a Kogan's lid twitch. In the first square, we see this gentleman looking down, and what he's doing is resting his eyelids. The resting the eyelids helps to kind of restore some of his strength to the eyelid. As he looks forward again, you notice how his left eye, it's still very droopy, but you can see quite a bit of the colored part of the eye, or the iris. Well, that's because he's been resting it, and so that lid has just a little bit more energy. But very shortly thereafter, in C and D, we see that lid fatigue again. So Cogan's lid twitch is just where they look down and then they look up, but the eyelids come up just a little bit and then down again. It's the twitch. Here's another test that we'll sometimes do clinically in the office. It's reliant on the idea that your eyes like to do the same thing, and so they get equal innervation from the brain. If both of your eyelids are weak and droopy and kind of falling down, they're getting the same innervation. The brain is trying to keep them open, but it just really can't. It's too much. But it's sending the same amount of signal to both eyes. When the provider in this video lifts the gentleman's left eyelid, now he doesn't need that much innervation to the left eyelid. And so the amount of innervation that's coming out decreases to both eyes, and we see the opposite eyelid drop down. So what are the treatment goals? Well, the treatment is to get your strength back, and we do that in a few different ways. One thing we do is treat the symptom directly with a medication called pyrostigmine. Pyrostigmine we'll talk about again in just a moment, but it helps to increase the amount of acetylcholine in that neuromuscular junction to compensate for the blocked receptors. You also have to control the underlying problem. You want to keep that immune attack from actually destroying the neuromuscular junction and making the whole situation worse. If there's a thymoma present, you want to do a thymectomy to make sure that you're minimizing the progression of the myasthenia and also addressing any potential that there could be a cancerous change there. And then treat with therapy, physical therapy, occupational therapy, speech therapy, respiratory therapy. All of these things are important as an adjunct to the medication. And of course, this is all superimposed on a normal life that everybody is just trying to live. And so there's lots of support that people need outside of just the medicine and the therapy in their lives to help them live with chronic issues. So back to the neuromuscular junction. I illustrated here with as I did before in the earlier slide, the acetylcholine receptors within the blue. The acetylcholine is the little green squares, and the little green squares are trying to fill up all those acetylcholine receptors, but some of the receptors that they're getting to have been blocked by antibodies. So what we do with pyridostigmine is we stop the breakdown of the acetylcholine. There's a chemical in the neuromuscular junction called acetylcholine esterase, and its job, the little Pac-Mans in the picture, is to chew up the acetylcholine. If we can stop the acetylcholine esterase from chewing up the acetylcholine, then we have more acetylcholine to go around, and we flood that neuromuscular junction so that all of the receptors that are there, every single one of them that we can reach, is stimulated by acetylcholine, and then we can maximize the response to that muscle. In addition to acetylcholine, as I've said several times, we need to control the immune attack. And so we use immune modulating or immune suppressing medications to do that. Each one of these medications affects the immune system in a different way. And the downstream effect of that is to, again, minimize the antibodies as much as possible, stop that membrane attack complex from forming, preserve the neuromuscular junction, and try to keep that neuromuscular junction as healthy as we can. Prednisone is a mainstay first-line medication for myasthenia gravis. IVIG and plasma exchange are very important tools in our arsenal for treating myasthenia when it's really acting up. Azathioprine, mycophenolate, methotrexate, rituximab, tacrolimus, cyclosporine, and eculizumab are all medications that help us to control that underlying immune problem so that we can keep that neuromuscular junction healthy and unblocked. Selecting the appropriate medication, as with any medication, is always very individualized, and so this has to be discussed in depth with your treating physician so that you can choose one that's right for you. A myasthenic crisis is a problem where a myasthenia just gets out of control, and the myasthenia causes dangerous weakness in breathing and weakness in swallowing. And this is where we use the biggest tools in our arsenal, the quickest, which is plasma exchange and IVIG. Steroids are a portion of this too, and that has to be done with some caution. And then pyridostigmine. Pyridostigmine, when people are feeling well, is very helpful, and it's still helpful in myasthenic crisis. But treatment of myasthenic crisis has to be done by somebody who really knows what these medications are going to do in that situation, because sometimes pyridostigmine can cause issues with excess salivation that can cause a problem with breathing. Steroids can very transiently worsen myasthenia gravis in some situations. And so these are tools that we absolutely use and we absolutely need, but they have to be used carefully and by people who understand how to use them. There's another antibody called anti-MuSK that we talked about very briefly early on, and it's a little bit different in the way that we manage it. Steroids and immune suppressive or immune modulating therapy are still effective. Plasma exchange tends to be more effective than IVIG. It does not respond as well to pyridostigmine because the underlying problem is a little bit different. Thymectomy has not been shown to be helpful, but rituximab has been shown to be particularly effective. And these are just small points with anti-MuSK just to consider. As I said, myasthenia tends to affect women who are younger, in their 20s and 30s, and this is a time when lots of women are planning families, and we obviously don't want myasthenia gravis to get in the way of that. But you have to plan for it, and you want to make sure that you talk to your physician so that you can optimize the control of the myasthenia gravis before you have to manage the pregnancy, which can be challenging in and of itself, along with the myasthenia if the myasthenia is not optimal at that time. So make sure the myasthenia is as controlled as it can be before getting pregnant. You also want to make sure that you're coordinating your care with your neurologist and a high-risk OB so that they can be ahead of any potential issues and make sure that they're monitoring you in a way that keeps you and the baby safe. Myasthenia gravis may worsen during the first trimester of pregnancy. This occurs at times, but it tends to improve in the second and third. The risk of a myasthenia gravis exacerbation is slightly increased after a child is born as well, and that has to be monitored for too. A complication that we occasionally see in childbirth in everybody is a problem called eclampsia or preeclampsia. And in that situation, OB tends to turn to magnesium sulfate to help control that. But the problem is that magnesium can worsen myasthenia gravis, and you could precipitate a myasthenic crisis by giving a woman a high dose of magnesium sulfate, which is again why you want to make sure that your OB is a high-risk OB, they're knowledgeable, and they're communicating with your neurologist so that things like that are well understood before a situation arises. Vaginal delivery is still optimal for mother and baby when possible, and you want to make sure that you monitor the baby after birth because they can sometimes get antibodies from mom. Well, all babies get antibodies from mom, and it protects them when they're newborns. But the myasthenia antibodies can cross as well, and when that happens, it can make the baby weak for a short period of time. And the problem will go away. The baby doesn't have myasthenia gravis per se, but they do have some of those antibodies that are causing a little bit of an issue. Controlling the myasthenia gravis in pregnancy is important to reduce that antibody effect on the fetus and newborn. Pyridostigmine, which we talked about, is safe in pregnancy specifically, but some of the IV medicines that are similar can cause uterine contractions, which could potentially cause a problem. Prednisone is safe in pregnancy, and it's still first line. And azathioprine and cyclosporine are also safe. On the other hand, methotrexate and mycophenolate are contraindicated due to the risk of birth defects. And plasma exchange and IVIG, it becomes a risk-benefit assessment with using those medications if a myasthenic crisis emerges. With myasthenia gravis, there is a higher incidence of thyroid problems, and patients who have one autoimmune disorder are more prone than the general population to develop a second. There are medications to be careful of with myasthenia gravis, and you always want to make sure that the physician who's prescribing your medications is well aware that you have myasthenia gravis and that some medicines can worsen it. Common medications that can worsen myasthenia gravis include some blood pressure medicines I, as a physician, use every single day in other patients, like beta blockers and calcium channel blockers, magnesium we talked about, Botox or botulinum toxins that are used for a multitude of things can worsen weakness in myasthenia gravis. Muscle relaxers, antibiotics are one I think that people don't often think about but need to, and these include common antibiotics like levofloxacin and azithromycin, as well as many others. Chloroquine and hydroxychloroquine can worsen myasthenia, and prednisone, when it's started at high doses, can have a transient worsening in the first couple of weeks, and so you have to be careful with it. To see a full list of myasthenia gravis medications that require caution or are contraindicated, you can see this at the Myasthenia Gravis Foundation of America website under cautionary drugs. Other things that can worsen myasthenia: stress, which I personally am living completely without. I have absolutely no stress, as I'm sure many of you also do not have that. Fatigue can worsen myasthenia gravis, and so can heat, which is a common issue with lots of autoimmune disorders. And then there's, how do I know what's not the myasthenia and when to turn somewhere else? Well, typically myasthenia gravis, although it can cause joint pain and muscle aching, myasthenia gravis weakness is usually not painful. It shouldn't cause a shooting pain in your leg or a shooting pain in your arm. Vision change is common in myasthenia, but if your glass is corrected, it's not the myasthenia gravis. Chest pain is usually not present in myasthenia, although the shortness of breath could create a sensation of tightness, and that really needs to be evaluated urgently anyway. Mild symptoms that do not improve with rest are not likely to be myasthenia gravis. Bowel or bladder incontinence is not a typical symptom of myasthenia gravis, although pyridostigmine, every drug has side effects, and one of them that we see with pyridostigmine is stomach upset and occasionally diarrhea and bloating and things, and so that could cause an issue, especially if you're weak and it's hard for you to get to the bathroom. If you have a sudden onset of weakness or sudden onset of speech changes, that is myasthenia. It's fatigue. It'll fatigue to reach that level of weakness. But if you're fine 1 minute and you're slurring your words the next, there are other things such as stroke that are high on the differential, and that should be evaluated in an emergency department. When we think about treatment, we often will think, well, is my medication working for me? And this is common, not just with myasthenia, but across the medical spectrum when we're starting things. With myasthenia gravis, this can be a difficult question because working for you does not always mean that the symptoms go away completely. That's the goal, but it's not always an attainable goal. Sometimes all we can do is make it better. If side effects are a problem for you, but the weakness is better, that might be a sign that there's another medication that may be better suited for you so that we can treat the weakness and get you feeling better without giving you side effects that make you feel awful. You want to be careful with weaning any medication, and any worsening should prompt discussion with your physician right away. Another issue that we see with myasthenia very frequently is dysarthria, which just means the speech is slurred, and dysphagia, which means that people have a hard time swallowing. With the speech, this difficulty tends to occur during times when you've been talking for quite a while, unless your problems are less well controlled, and then it may occur more quickly. But periods of rest during speech can help you kind of pick up and get going again. There are also adaptive communication devices, iPads and things, that your speech therapist can help you with if your speech difficulty is prominent and you need that kind of assistance. When it comes to swallowing in myasthenia, sometimes we need to change the diet to reduce the need for chewing, less steak, more fish, so that the food that you're chewing is softer. That can be really helpful. It helps you maintain your ability to eat without expending your energy on trying to do it. Techniques to improve swallowing, such as tucking your chin, can be helpful, and these are things that should be taught to you and coordinated by a speech therapist. Periods of rest, not only during speech, but during meals, can be helpful, and changing the food consistency can reduce fatigue. Sometimes when people have lots of difficulty with thin liquids, thickening them can be helpful. And again, speech pathologists are very, very helpful in helping to discern what's the most appropriate diet for you. Exercise in myasthenia gravis is a very important thing and an interesting question, and something that people often get confused about in neuromuscular disease in general. It's important to maintain the strength and stamina of everybody, for all of us. If we don't move and we don't get up, we get weak. And for most of us, we have enough kind of baseline strength that we can kind of muddle by anyway. But if you have myasthenia gravis and you are already weak, maintaining what you can by preventing what's called deconditioning is essential. Strengthening will help to improve your mechanics so that when you're walking, you don't have quite as much sway in your hips, and the position of your spine is a little bit more normalized. And that can help to reduce stress on your joints and your back. Because prednisone can cause bone loss over time, weight-bearing exercise is important because it helps us to strengthen bones. And increasing strength and stamina help to improve the function and help to improve your function, which lets you enjoy your life, to get out and do the stuff that you want to do. So with myasthenia, considerations in exercise are weight-bearing, keeping the intensity low to moderate, take rests while you're exercising, and monitor your fatigue. And if you find that you're still fatigued or sore more than 2 hours after you've exercised, you did too much. You have to cut that back. You also want to exercise when your medicine is working. So you want to try to get exercise when you're feeling your best after your medication dose or at peak medication effect. And where to focus. We want to focus on strengthening arms, legs, core, resistance bands, hand weights, aerobic exercise as tolerated with periods of rest as needed. Stretching is important. And the program should be designed by a physical therapist to ensure that it's appropriate for you. And then be gentle. You want to avoid activities that are very high intensity. Make sure you're resting enough. Don't expend too much energy. You want to make sure that you make your workout sustainable so that you can do it regularly. If you exercise to a point where you can't function, you won't be able to do it again tomorrow. You want to do little chunks, things that feel comfortable for you, that help you function better, not things that make you so tired you can't do the other things you need to do. And you should feel back to yourself within no more than 2 hours after exercise. Physical and occupational therapy are important because they help you with strengthening and stabilization, and they can teach you compensatory strategies to help you do things that might be challenging for you. They can also help with ergonomic assessments, like at work. What in your workspace could be optimized to help you function better so that you're not worn out by the end of the day. They can also help with assessing needs for any kind of adaptive equipment. Is a walker right for you? Do you need that? Do you need a chair with power assist at times to help you get through? Things like that, a therapist can help kind of ferret through. And then you want to make sure that you're communicating with your physical therapist. If the therapist isn't meeting a need that you feel like you have, it might be because they don't understand that you have it. So if you communicate very clearly, make your needs known, it's their job to listen to you and to help you find a way to solve those problems. That's what they're there to do, so don't be shy about asking. Respiratory therapy can be helpful as well, especially after an exacerbation, and there are some breathing exercises that you can do to help. This has been shown to strengthen breathing after exacerbations and shown to improve overall respiratory function and parameters in patients with myasthenia gravis. So one of them is something called inspiratory muscle training. This is similar to an inspiration spirometer that we use in the hospital, where you're blowing out against a device that provides some resistance and trying to meet gradually increasing goals. And similar to the exercise that you're doing, your other exercises you're doing, small goals and incremental improvement is what you're looking for here. Other things that can help improve breathing are something called pursed lip breathing, where you inhale, purse your lips, breathe out. And that increased resistance can help with respiratory force. And then diaphragmatic breathing, which is belly breathing. It's instead of expanding your chest to get the air in, expanding your belly to get the air in. And this is a diagram kind of showing how this is done. You put a hand on your chest and the other on your stomach. Take a breath, feeling your stomach move outward, and breathe out slowly, pressing lightly on your stomach. You want to feel your belly move, not your chest. And repeat the exercises as you're able. To wrap it up, myasthenia gravis is an autoimmune disorder. It's caused when the immune system blocks contraction, blocks the communication of the nerve with the muscle. It's important to control the symptoms so that you can function, but it's also important to control the underlying immune attack on the neuromuscular junction. Exercise is always good, but be gentle. And physical therapy, occupational therapy, and speech therapy can help you. And I think that the most important thing is to communicate with your doctor. Make sure that you have a doctor that's listening to you and you feel like your needs are heard. Communicating with your doctor is key to getting those needs met. And that's all I have for you. Thank you for your time.
Thank you for your wonderful talk, Dr. Frey, and thank you for joining us today to learn more about understanding, living, and thriving with MG. If you found value in this information, please consider a donation to the Myasthenia Gravis Foundation of Michigan. Your donation helps ensure that we can continue to offer this important info to our MG family going forward. You can donate by texting MGMI to 41444 or by visiting our website, mg-mi.org. We look forward to seeing you tomorrow for Dr. Eileen Antonio's talk on telehealth for myasthenia gravis, beginning at noon Eastern Time.